serious complication. So it does seem that mineral bone disorder associated with the CKD has a major impact, as much as any other thing, on the cardiovascular system. I'm going to talk about this point, but let me first enlighten you with some general knowledge related to what's happening to our patients related to the cardiovascular system. Naturally, we all know that the cardiovascular morbidities in CKD would be just like the general population, as you can see: coronary artery disease, infarction, heart failure, cerebral vascular disease, fibrillation, peripheral arterial disease, and sudden cardiac death. But always remember that coronary artery disease is on the top of the list, and it is the most serious cardiovascular complication and associated with the highest rates of mortality. Coronary artery disease is serious, and I will come to show you why in CKD in particular. If you look at these pie charts, you can easily recognize that the general population here to the right-hand side, left-hand side, right-hand side, yes. When you compare the breakdown of congestive heart failure, myocardial infarctions, as you can see here, you find that for people who have CKD, there is a highly significant differences in the prevalences of these various entities, meaning that CKD in itself is another added burden on the general population, leading to more and more heart disease. This is an important fact. Okay? Some studies looked into this particular point, and you can see these major mega trials that addressed thousands of patients could find that the cardiovascular outcomes are much more serious for patients having CKD, undermining and underlining the fact that CKD is a burden to the heart. The more, if a patient has a CKD, his cardiovascular problems, such as this particular point that was addressed, the ventricular dysfunction, is much more. In this publication, it is quietly documented that the patients with CKD would experience higher mortality and more adverse cardiovascular events, which is much more than the general population, even if adjusted for the conventional coronary risk factors such as smoking, obesity, genetics, diabetes, hypertension. If you put these aside, still a patient will have more coronary disease. So there's something unique to CKD, making the hearts more diseased than other people. The KDOQI, which is the kidney organization addressing the quality initiatives, I'm sure you've heard about the KDOQI, also stated that all patients with CKD should be considered in the highest risk. Imagine the highest risk tertile of patients having cardiac problem, again documenting the fact that this is irrespective of the traditional risk factors that we all know. For diabetic patients, the same fact is there. We know that urinary albumin creatinine ratios are independent risk factors for cardiac problems in type 2 diabetics, while the decline in estimated GFR, meaning the progression of CKD, is also regarded as an independent risk factor for cardiovascular problems. This table is very illustrative and important, because it shows you the differences between the traditional risk factors, which may quite well be in a patient with CKD, these traditional risk factors. I don't have to go through all of them. I'm sure we all know them quite well. Imagine a patient with CKD that would have one of these, or two, or three, or all of them, plus another set of risk factors. So this is now quite clear why a patient with CKD would have a more serious cardiac problem than a patient without CKD, because just having CKD, all of these together affect the cardiovascular system: inflammation, infection, anemia, dyslipidemia, and of course, what I'm going to talk about today, which is the mineral bone disorder, the CKD-MBD. Always atherosclerosis, it is at the core of the problem, and atherosclerosis may be due to dyslipidemia, genetic factors, the way people live and eat, and this would affect CKD in this fashion, whether due to association of conventional risk factors or the non-traditional risk factors related to uremia. And these are some of the things that are disturbed in uremia or CKD that definitely promote the occurrence of atherosclerosis. Decreased clearance of the AGEs, the catabolic state, the increased oxidative stress, and so forth. All these are making the atherosclerotic process more in CKD. I'm trying to press you that the heart is in a more difficult situation in CKD because these patients would have the traditional risk factors, most of them, all of them, plus other things related to just being a patient or a victim of chronic kidney disease. It is well understood that uremic toxins are very harmful to the body and to the system, and there is more than 100, maybe 160 different uremic toxins, and every now and then there's a new publication of discovery of another uremic toxin. Some of them have unique and specific poisoning effect to the body, such as the one I'm addressing now, which is called indoxyl sulfate. And this has been studied in the year 2009, and this uremic toxin has been related to endothelial cellular proliferation and aortic calcification. So here we have one of the factors related to CKD that is related to the coronary problems that is subject to further insult by other pathways. We always have to keep in our mind, coronary artery disease is the leading cause of death in our patients, but the situation, as I'm trying to show you, is rather complex. Complex in pathogenesis, complex in the diagnosis, and definitely this will be complex as well in the management. Let's have a look at diagnosis after this brief overlook of the pathogenesis and see how diagnosing ischemic heart disease will also be complex. We do know that any ischemic patient should have ischemic pain or exertion and so forth, and you make an ECG, you find the ST segment elevated, right? This is what we know of depressed. This is what we know in the general population. But this things is completely disturbed in the uremic patient because the classic triad of ischemic symptoms, elevated cardiac biomarkers such as troponin, for example, and CPK and so forth, all of this is disturbed. ECG changes are frequently not present in CKD, and patients usually present simply with systolic dysfunction, and you just come to see you in the clinic with heart failure, and you don't know what is causing the heart failure. They've been having a very long time with anemia and a long-standing hypertension, and it is well understood that these have a bad impact on the ventricle. You can see here the ventricle is hypertrophy. hypertrophy, and with such a hypertrophy ventricle, when you look at the ECG, you will see this strain pattern, which mimics very much ischemia. So this is making the diagnosis of ischemia not easy. The problem of coronary artery disease relates so much to the progression of CKD, meaning when they looked at patients with CKD at different stages, they could find a scoring system called the Toxins system that measures the diameter, assessing the narrowing of the coronaries, is increased. The more the patient has a stage of CKD, you would find that this scoring system related to the coronary diameter is getting worse. Something is happening with the progression leading to this change. Now, back to the traditional versus the risk factors related to uremia, and we start to address in particular the abnormalities in the calcium and phosphorus metabolism, which is the CKD-MBD. What is this disturbance in particular doing to the heart? We have to understand, to prevent the damage of this disturbance, that this disturbance is of two components. One component related to the bone. I'm not talking about this today, but I could answer any question if you like. And the other component is related to the cardiovascular system, and that's why I'm here today. So, there is a very sophisticated and a complex crosstalk between the kidneys, the vessels, and the bone, and it's so intense that I cannot follow it and tell you all that has to be said in just a few slides. It's very complicated, and this linkage is revealing a lot of secrets nowadays, which will be very beneficial in the future as therapeutic, new therapeutic targets. One of the major problems related to the disturbance in the calcium and phosphorus and PTH and the results of this is in the occurrence of a vascular calcification. Vascular calcification can happen in the general population with the early atherosclerotic diabetics, yes. Dystrophic calcification has been described earlier, but this type of calcification I'm talking about is very much unique to uremia. And you would look at an atherosclerotic artery here to see the atheroma related to the edema, while here we have some other form of pathology which is quite different, affecting the median, called the Monkeberg calcification of the middle artery calcification. This is unique, and it may lead to a special entity called calciflaxis or uremic arteriolopathy, and this form of calcification may affect not only the coronary but also the aorta. Mind you, both forms of pathologies can coexist in a patient with CKD. Why is this calcification so serious? Because it would affect the coronaries, and when you look to this graph, you can easily appreciate that if more than one artery is affected by calcification, the probability of survival would be less. The more you have arterial affection by coronary calcification, over here, this arrow, this is the coronary calcification, the contrast multi-slice CT. If you have more than one artery, this means the probability of survival is less. Not only this, when they studied and addressed the amount of calcification in each artery in a scoring system called the Agassiz score, they could often realize that if a patient has no calcification whatsoever, you can see that the probability of survival is the best And once the calcification score increases down to 4, for example, you find the probability of survival is decreasing. Calcification, I'm trying to prove to you by these data, is related to mortality. The immune system is involved in initiation and the pathogenesis of most of the diseases we know, and maybe the ones that we have not addressed. The immune system has been recently shown to be associated also with the occurrence of chronic calcification. I don't want to really go through the details of this graph, but if someone is interested, you better look it up at the NDT a couple of months ago this year. Very interesting article showing that the abnormalities in the high-density lipoproteins in these patients trigger some kind of receptors called here, toll-like receptors. Anyway, they initiate signaling within the cells that will eventually the pro-inflammatory cytokines, leading to various pathological changes within the walls of the arteries. Lately, recently, just a couple of years ago, a new mediator, and this publication is just last month released. This sclerostin is released from the bone, and is one of the growth factors related to bone remodeling. We don't want too much of sclerostin because it leads to remodeling of the bone. We don't want much of it, and now there is a treatment for osteoporosis where we have monoclonal antibodies directed against sclerostin, and this sclerostin has been shown to be associated with chronic calcification without going through the details. Also, one of the important players in the field, or this field of chronic calcification, is the fibroblast growth factor with its associate, the clotho. Before, we didn't understand that clotho, which is important for the function of fibroblast growth factor 23, responsible about diuresing the phosphorus from urine. And this mechanism is not working, of course, in CKD. Now we understand that clotho can be active on its own. And if a mouse does not have clotho, by simply knocking out the gene, he has premature aging, he ages, becomes very old, and all his vessels start to calcify. So, clotho is important to prevent calcification. Recently, just last month, this wonderful article that I regard as a real breakthrough in this aspect of nephrology has shown us that for many years, we all know that the stents the cardiologists put in the coronaries impregnated, or what they say, eluding sirolimus, which is a PSI, a proliferation signal inhibitor, one of the mTOR inhibitors, prevent the proliferation of the endothelium. This is very nice. But no one knew why this was happening, why sirolimus was preventing the proliferation of the endothelium. After this breakthrough study, it is now understood that sirolimus and its counterpart, or the other drug like it, infrolimus, which are both mTOR inhibitors, both of them are upregulating clotho. We understand that clotho deficiency leads to calcification. Now, the mTOR inhibitor, sirolimus or infrolimus, are upregulating clotho. Now we have a lot of clotho or normal levels. This is very beneficial to prevent the proliferation of the endothelium and the damage that occurs. Maybe in the future we'll be using sirolimus in this regard, but we have to understand that mTOR inhibitors in general are drugs known for their capacity to cause dyslipidemia. Other upregulators of growth that maybe we are using not for this specific aspect is ACE inhibitors. We are all using ACE inhibitors for our patients, active vitamin D and pioglitazone for diabetics. These are also important drugs in upregulation of growth. To remind you what happens when the kidney starts to fail, the calcium triol level starts to drop. The FGF23 starts to rise, and soon the PTH starts to rise. PTH is very important for modeling, but we have to understand that it is a very important risk factor for the heart as well, and the chronic calcification. PTH itself is injurious to the endothelium, not just the heart, and it intoxicates the cardiomyocytes, eventually to a form of cardiomyopathy. So we have to be very wise in treating PTH. We have to treat our patients having hyperphosphatemia, hyperparathyroidism, to limit not too much suppression for fear of dynamic bone disease. Phosphorus will always be regarded as a very important and independent risk factor for coronary calcification, and we have to do all we can to prevent hyperphosphatemia. The last point, I'm not going to take too much, is the management, which is also complex. Why is it complex? Because as I have shown you, there's an ordered relationship of the typical risk factors, hypertension, diabetes, and so forth. There is ordered relationship between these risk factors and the other risk factors present in our CKD patients. Whatever trials were made related to various drugs, always the design exclude patients with advanced CKD, so we don't know much about these patients, so we do have doubts. We have a problem as such, because our failure to deliver potentially effective medications to the people who really need them would result in preventable morbidity and mortality. It is preventable if we just adopt what we know with knowledge. And also this is resulting in a therapeutic nihilism, which means a disbelief amongst ourselves. We don't believe that treating these patients is going to make any difference. So there is a lack of appropriate risk factor modification and intervention adding to the problem. Despite data that I have shown you, it is a fact. CKD is damaging the heart, and we know how and we know what to do. We need more and more education and not to give up. So although the facts clearly show this relationship, it is a very complex situation, as I tried to show you today, but we shouldn't give up. We should accept the challenge and use the evidence and whatever drugs we have to improve the lives of our patients. I hope I didn't take too much time. I thank you all for your attention.
Okay, do you have any question, Professor Tarek? Everything is clear? Clear?
I'll ask you questions.